Welcome back to the Medical Entrepreneur IV Chelation Training Series. I'm Adam Sewell, MD, and in this video E2, we're going to walk through a case study on chronic mercury exposure in an adult patient. Unlike acute toxicity, this scenario often goes undetected for months or even years, and as you'll see, identifying the source and treating the patient takes both clinical precision and environmental insight. As always, this video is for educational purposes only. Please follow your local guidelines and clinical protocols when treating actual patients. Let's jump into the case. Patient, 42-year-old male. Occupation, works in a dental lab preparing amalgam fillings. Symptoms, memory issues, fine tremor, chronic fatigue, intermittent headaches, metallic taste in mouth. Labs, 24-hour urine mercury, elevated at 85 micrograms per liter. Serum creatinine and BUN, normal. CBC, within normal limits. TSH and cortisol, normal. Diagnosis, chronic elemental mercury exposure, likely via inhalation of mercury vapor in the workplace. This case is typical of low-grade, long-term exposure in dental or industrial environments. The symptoms can mimic anxiety, burnout, or early cognitive decline, but when you know what to look for, the picture becomes clear. Let's break down how to manage this case step by step. Mercury can affect two major systems, neurological and renal. Neurological signs, tremors, memory loss, difficulty concentrating, mood instability, insomnia. Renal signs, proteinuria, fatigue, flank discomfort, mild hypertension. This patient is primarily neurologic, which aligns with inhaled elemental mercury exposure. In contrast, ingested mercury, for example methylmercury from fish, may show up with more systemic and renal symptoms. Always ask detailed environmental questions and track symptoms over time. Create a symptom log or use a digital tracking tool if available. With mercury toxicity, we often choose between two chelators, DMPS or DMSA. Let's go over how to use each one properly. DMPS, 2,3-dimercapto-1 propane sulfonic acid. Route, IV or oral. Dose, IV, 250 to 500 mg per dose, 1 to 3 times per week depending on severity. Best for high body burden, strong neurological symptoms, or poor GI absorption. Monitoring renal function, electrolytes, urine output. DMSA, dimercaptosuccinic acid. Route oral, typical dose, 10 milligrams per kilogram every 8 hours for 5 days, then every 12 hours for 14 more days. Best for milder cases or outpatient use. Notes, less aggressive than DMPS, but better tolerated long-term. In this case, we chose IV DMPS given the patient's neurologic symptoms and occupational exposure history. After initiating treatment, you need to monitor more than just labs. You need to track how the patient feels and whether exposures are continuing. That brings us to a vital but often overlooked part of mercury detox: workplace mitigation. If you don't stop the source of exposure, chelation is like bailing water out of a sinking boat. What to recommend? Immediate assessment of the worksite. Refer the employer to an industrial hygienist. Recommend proper ventilation and mercury vapor scavenging systems. Require the use of N95 masks or powered air purifying respirators, PAPRs, if exposure can't be eliminated. Suggest relocation of the patient if necessary during active chelation. Provide documentation to support medical leave or workplace accommodation as needed. Also, advise the patient to avoid fish high in methylmercury, such as swordfish, king mackerel, and tilefish, during the detox process. Your follow-up plan should include repeating urine mercury levels every 4 to 6 weeks, tracking neurological symptoms through a daily log, monitoring renal function and CBC monthly during active chelation, adjusting frequency or agent based on tolerance and progress, reassessing workplace conditions regularly. In many patients, tremors and fatigue improve within 1 to 3 months, while memory and cognition may take longer. Let's summarize the key takeaways from this case. 1. Chronic mercury exposure often presents with subtle neurological or renal symptoms, so keep a high index of suspicion, especially in dental, lab, or industrial workers. 2. Use DMPS for more aggressive IV detox or DMSA for outpatient oral treatment. 3. Always address the source of exposure or treatment may fail. 4. Monitor labs and quality of life indicators and adjust as needed. In video E3, we'll go over a case of iron overload, including the use of deferoxamine and how to tailor chelation protocols for patients with chronic transfusion needs or hereditary hemochromatosis. Thanks for watching video E2 of the Medical Entrepreneur IV Chelation Training Series. I'm Adam Sewell, MD, and I'll see you in the next video.